life and access to care, and we have an opportunity to do that this year. But first, I just want you to see Henry. This is Henry. He's 9 years old. He lives in Grosse Pointe, Michigan. He loves people. He greets everybody with a big hug. He loves performing. He's in dance class and sings karaoke at home. The challenge is he's also living with a number of pre-existing conditions, including Down syndrome, autism, and severe reflux. As you can imagine, he's been in and out of the hospital, a lot of challenges, and his mom said, Kara said, if we didn't have access to affordable health coverage, we would have been bankrupt before Henry was 1 year old. And so, first let me say, in addition to all of the cuts on Medicare and Medicaid, as well as health research, which I'm very concerned about that are in the budget, there's nothing that stops the lawsuit on the ACA going through the courts that would take away coverage on pre-existing conditions and everything else under the ACA. And I am very concerned that when the court initially agreed with the fact that the ACA should be repealed, including pre-existing conditions, the president tweeted, "Great news for America," not great news for Henry. And so I'm very, very concerned about that. The area where we have the opportunity to work together and to really make a difference is in the area of community mental health and addiction services. And when you said grants are not enough, boy, are you right. We have champions on this committee for efforts around addiction and opioid treatment and so on. It's always a grant. When the grant runs out, so sorry. So the only folks that are asked to do that in healthcare are the mentally ill and people with addiction. And so, as you know, Senator Blunt and I, and now we have 12 members, 10 Democrats, 10 Republicans. We're adding people in pairs, and we expect to add more people. We have a House bipartisan effort to expand an 8-state demonstration project that was set up that literally shows that we save money. People aren't in jails, there aren't in emergency rooms, but when you do quality community mental health, outpatient care, and addiction services, you not only save lives, you save money. And so we want to expand that. The chairman's very supportive, the ranking member, many people. There are 19 states that actually have meet the quality standards now, are ready to take that next step, and we are also doing grants to help every state be able to get ready. But I wonder, there's been a study that has shown in the last 2 years some of the results, the positive impacts that have happened as a result of what has been done in the Excellence in Mental Health and Addiction Treatment Act. And I wonder if you might share some of those, if you're aware of the results that we've seen in just 2 years.
Absolutely, Senator, and thank you for your leadership on the CCBHC issues. This program, the Certified Community Behavioral Health Clinics program, has already served over 24,000 individuals as of August of 2019. These are clinics, as you said, that provide comprehensive, coordinated range of evidence-based treatment and behavioral health services to individuals. And the results show that we see that they are making services more convenient. They're introducing more frequent appointments, tailoring services offered to diverse populations such as school-aged youth and veterans, and they're expanding access to care in our communities. So in our budget, we propose to extend this program until through FY 2021 for the 8 current participating hospitals, because we are believers in this program, and obviously happy to continue working with you as we think about expansion to other states.
Well, thank you, Mr. Secretary, and I want to thank Chairman Grassley and Ranking Member Wyden for putting in the full extension across the country to the states that have met the quality standards into your health care bill that's come forward on health care extenders. We have a chance in May to do this right. I will also say that if you want to talk to folks that are excited about this, talk to a sheriff in one of the communities where folks are no longer going to the jail. They are now getting community outpatient treatment. Talk to the hospital folks who are running emergency rooms who no longer have folks sitting in their emergency room, but they're getting care through the 24-hour psychiatric emergency centers that have been set up. And the final thing I would say, Mr. Chairman, is that this is actually a good news story in that CBO, who we all struggle with around healthcare savings, has actually dropped more than in half their original estimate on what it would take for us to pass Excellence Act this year. And so I hope you will lean in heavily with us, because it's my intent to make sure the mentally ill and people with addiction are not left behind this year. Thank you.
I'll pass over Senator Menendez and go to Senator Carper.
Mr. Secretary, welcome. Thank you for taking on a tough job, and we appreciate that and the work that you're doing. Don't always agree, but we appreciate it nonetheless. I think Senator Grassley has already raised the issue of bipartisan legislation that he and Senator Wyden and others on this committee crafted in order to try to reduce prescription drug prices for Medicare beneficiaries. And it's not every day that we have the kind of consensus that we had in this committee on this issue, but we're encouraged by that. As you know, the legislation would lower drug prices for seniors, would lower drug prices for Medicare and Medicaid, and require drug companies to publicly justify the prices for their products in a day and age when we're trying to find ways to save money with respect to pharmaceutical costs and other healthcare costs in ways that are humane to people. I think this is a very good effort, and we're proud of it. Let me just ask, do you and the President support the Finance Committee's bipartisan bill to reduce drug prices?
We've been very active in working with the bipartisan leadership of this committee to try to advance this legislation. If we want to get this or some other comparable bipartisan package through, we need to do this. This is certainly one that fits the bill. If there are other approaches that we need to take to try to get this to the floor and get it passed, we're open to that, but we've been very deeply engaged with the Democrats and Republicans on this committee to advance the Grassley-Wyden legislation.
Thank you. Some of our Republican colleagues believe that the finance bill would amount to price controls in the pharmaceutical industry and jeopardize innovation for new therapies. And as a former CEO, a native, I think, of Salisbury, Maryland, but as a former CEO of a major drug company, do you agree with these concerns? And the second half of that question would be, do you think drug companies can continue to innovate under the Finance Committee's bill?
With all respect, I fundamentally disagree with the notion that the inflation penalty provisions that are in the Grassley-Wyden bill constitute price caps or price controls. These are reasonable restrictions on price increases that create basically a financial disincentive to the year after year price increases that we see. And as long as those incentives are in the system, we will continue to see year after year price increases, and the Grassley-Wyden package would contain that. It's important to remember, these drug companies already sign contracts with the middlemen with long-term price predictability guarantees. So this is not an alien concept to the drug companies. This exists as a commercial practice already. We would just get the benefit for our seniors and our taxpayers through this program. And I'm sorry, Senator, there was a second part of your question. I want to make sure I get that.
Yeah.
Senator Carper, before you repeat that second question without taking time away from you, wouldn't another way of saying it, since we pay $138 billion of taxpayers' money for Medicare drugs, that we would be just capping the subsidy that we give to give to pharmaceutical companies?
Well, it does, and that's one of the really important innovations of the Grassley-Wyden packages. It actually changes the dynamic. Right now, interestingly, the middlemen who run these drug plants have every incentive actually for the drug companies to jack up their list price, because it races the senior to what's called the catastrophic phase, where the government pays most of the cost of that insurance through the reinsurance. This would be fixed by Grassley-Wyden.
Thanks, Mr. Chairman. The second half of my question, I don't think you got to it, was, do you think drug companies can continue to innovate under the Finance Committee's bill?
Oh, absolutely. The changes here still leave plenty of room for profit margin, innovation, and investment. There would be no material impact in any way to the R&D enterprise in the United States, which we are all committed to.
All right. My colleagues hear me quote from time to time Matthew 25, which goes something like this: when I was hungry, did you feed me? When I was naked, did you clothe me? When I was thirsty, did you give me to drink? Doesn't say anything about when I desperately needed pharmaceuticals that saved my life. Doesn't say anything, did you provide that? But I think the intent is clear. And sadly, with respect to the President's budget, the answer to these questions is not entirely, but too often, no. Over 100 million Americans have, as you heard, as you know, over 100 million of our fellow Americans have pre-existing conditions. These folks depend on the Affordable Care Act's protections for their health care and the promise of affordable health insurance regardless of their health conditions. The President has doubled down, though, on the Texas lawsuit against the ACA, and this budget contains no plans, as far as I can tell, to replace the ACA if the court strikes down the law, which will leave millions of additional Americans stranded without health insurance, Medicaid, and high prescription drug costs, all while cutting taxes for the wealthiest among us. My question, Mr. Secretary, would how will the President protect Americans with pre-existing conditions if the ACA is struck down in the courts?
So the President has been very clear that he will never sign legislation that would replace the Affordable Care Act if it does not have adequate protections for those with pre-existing conditions. It's important to remember, though, that even under the ACA, there is a statement of protecting against pre-existing conditions. But let's say you're a two-person family making $70,000 a year in Missouri. You're going to pay over $30,000 a year for premium, and you're going to have over $10,000 in out-of-pocket. So I do think we have to not over-glamorize the current situation in terms of the protection of those with pre-existing conditions, because for those people, that insurance card is, in some respects, a meaningless protection for pre-ex conditions, and we want to work with Congress if there's the opportunity to replace it with something that really would work for people.
My time is expiring. Let me just conclude with this quick comment, if I could. My understanding, if the ACA is struck down in the courts, the President won't have to sign anything. That'll be it. And I want us to keep our minds and our eyes on that. Thank you.
Senator Menendez.
Thank you, Mr. Chairman. Mr. Secretary, you're a named defendant in Texas versus U.S., correct?
Yes, I'm one of them, yes.
Yeah. Is it true that this administration has taken the position that it will not defend the Affordable Care Act in court and support striking down the entire law?
The position of the Justice Department is that the individual mandate is unconstitutional and that as a result the other provisions in it are not severable from that individual mandate.
So in essence it would strike down the entire law, and the Justice Department is part of this administration, is it not?
Yes, they represent the administration in the federal courts, yes.
So therefore it is the administration's view that the entire law of the Affordable Care Act should be struck down. So if it's struck down, what's your immediate plan to replace it? If tomorrow the court decides that, in fact, the entire law is struck down, millions have health insurance who didn't have it before. Many, under the Medicaid expansion, have health insurance that didn't have it before. Millions have protections against pre-existing conditions that didn't have those protections before. Millions have no more lifetime cap, a ceiling on the expenditures that they have, especially if they have a serious illness. So what's the administration's plan? I haven't seen it yet, and I think this committee has jurisdiction.
So the litigation still has a very long way to proceed. The Fifth Circuit, as you know, has remanded the case to the district court for a very searching, detailed analysis of every provision.
Why are we going to wait? Why would you wait with the health care of millions of Americans and their fate to see what the court decides? It seems to me we've been hearing about killing Obamacare since it was created. There have been years to have your own version of what it is. Why would you wait till there's a disaster to then deal with the millions of Americans who have health care insurance? See this young man? He's alive today because of the Affordable Care Act. And like him, millions in my state and across this country are alive because of it. I don't know what you're waiting for. If you have a better idea, show us. But I have yet to see one plan that the administration has put forward over the health care of millions of Americans. What are you waiting for?
We would wait until there's a final judgment by the final court of authority. In this case, it would obviously be the Supreme Court. There is a very long process to go to even see whether the statute is struck down or even in part is struck down by the Supreme Court. These are hypotheticals at this point. We are faithfully administering the ACA now.
Well, let me just say, Mr. Secretary, these are hypotheticals that we don't play with. This is not some abstract consequence if it happens. Not some abstract consequence if it happens. Let me ask you this. The President's 2021 budget calls for zeroing out CDC funding for gun violence research. Did the NRA tell the administration to do this? Did you have influence from the NRA to zero out funding for gun violence research?
I've got no idea about any interactions there. I can tell you why we didn't put that in the budget is we have a tight budget. We have a 9% cut at HHS because the caps, the discretionary caps for this year go from, I think, 7.5% in 2020 to a plus 1.5% or 1% increase. In 2021, we are the largest non-defense discretionary part. We absorb a disproportionate share of that. And so we had to prioritize. I prioritized towards infectious disease, global health, and emergency
if we didn't
preparedness
have
at CDC.
$1.5 trillion tax cut unpaid for, driving huge debt, and we weren't further plussing up the military beyond everything that has been done, you'd have some money. It seems to me that understanding the consequences of gun violence, how we get around it, would save lives here in the United States. One of the priorities of a government is to save its people. Well, let me just ask you one final question in the less than minute that I have. The Remain in Mexico policy, misleadingly called the Migrant Protection Protocol, has forced over 60,000 asylum seekers to wait in dangerous conditions in Mexico for the U.S. Immigration Court hearing. Over 800 cases of murder, rape, torture, kidnapping, and other violent assaults against asylum seekers returned to Mexico have been reported. What mechanism or process is there in the Office of Refugee Resettlement used to identify and track children affected by the MPP? What does ORR systematically notify when an MPP-affected child is identified?
Well, as you know, HHS and ORR have no role in determining eligibility for the MPP, which aliens are enrolled in that, or whether an alien is allowed to enter into the United States. And if a child comes in unaccompanied, then it would follow the usual unaccompanied alien children program protocols. If a child returns with their family to Mexico as part of the MPP, that's not subject to the statute and ORR's jurisdiction.
Yeah, but to the part that the child is unaccompanied and ultimately is returned to family in Mexico, are you doing any tracking through MP?
So
No.
if children are determined to be enrolled in the MPP and ORR and DHS determine the child's parents are in DHS custody, or if they return to Mexico and leave the child here, we collaborate to ensure that we can safely reunify the child. DHS determines whether there is a criminal history that would preclude reuniting. We coordinate to DHS informs ORR's intake teams that the child's referral is with a family enrolled in the MPP, so that we try to keep track of everybody. If a child comes to us at the family's request that they decide to return to Mexico and leave the child here, we work with DHS to keep them in contact, as we do with any child in our care, to make sure they're in telephonic contact with the parents as regularly as possible. So we track that between them whenever we receive a referral like that.
Senator Cardin.
Thank you, Mr. Chairman, and thank you, Secretary, for your service. I want to follow up on prescription drugs first, if I might. You talk about the middle person, the pharmaceutical benefit manager, who is supposed to be there to protect the patients, and in reality, they're not doing that. And we have a chance of really passing a prescription drug bill in this Congress. So I hope we can follow the leadership of our chairman and ranking member and get a bill to the finish line. But I'm going to tell you one of my pet peeves. We're the wealthiest nation in the world. We spend by far the most on prescription drugs, and we have 200+ common drugs that are in shortage in America. These are relatively inexpensive drugs, and they are critically important for care. We're talking about newborn babies, the drops that they need. We're talking about bladder cancer patients who need the therapy drug that's not available for treatment. That's outrageous. No one is speaking out in regards to these necessary drugs being available to consumers in this country. We need your help to make sure that we include this so that we do look after the people in this country, and we recognize today that the pharmaceutical managers and the pharmaceutical benefit managers are not protecting the patients of this country.
Thank you, Senator. First, happy to talk about shortages, but I did want to give you a little bit of good news. You have been an advocate for many years of ensuring that CMS has a chief dental officer. I'm very pleased to announce that CMS is working through an interagency agreement with HRSA to bring on board a chief dental officer. Thank
Oh,
you.
wonderful.
Thank you for your continued leadership
You
there.
can dodge my questions anytime.
No, I'm
with
good.
that kind of news.
But thank you for your leadership. I completely share your passion around dental health and its central importance. In terms of drug shortages, there are several legislative proposals in our budget that would help us better prevent or mitigate medical product shortages. One of them would enhance FDA's ability to assess critical manufacturing infrastructure so we could collect better and accurate information about supply chain management. We have the FDA task force on drug shortages has 3 key recommendations, though. One of them is to create shared understanding of the impact of the shortages and the contracting practices, particularly around generics, that may be contributing to them, sole source procurements, low pricing, et cetera, that may be driving that. We also want to create a rating system around manufacturing quality so that we could actually have perhaps a race to the top in generic quality there on these drug shortages. And the third is to really promote sustainable private contracting practices. We've had a bit of a race to the bottom, I'm afraid, in terms of generic procurements, and it has led to these types of sole source generic providers.
I think every one of those suggestions are what you need to do, but you can get congressional backup to what you're doing in legislation that's moving through here. Help us create the legislative mandate so we don't have drug shortages in America, particularly essential drugs that are not being reduced solely because it's not as profitable as other drugs. And it's not, no one would argue that the pharmaceutical community are not making enough money. So why should we not have these drugs available? So let's look for a legislative backup. In addition, your budget is really good on telehealth. Appreciate that very much. We have bipartisan support here to expand telehealth into Medicare. We need technical assistance from your agency so that we can give you, again, the legislative backup to expand telehealth services in this country. That's another area where I think we can work together and provide a permanent legislative basis to expand make sure we don't have drug shortages and expand telehealth. So I welcome your help. I want to cover one other issue. Yes, I've heard your explanation on the Medicaid cut that you call just a reduction in growth. I can tell you in Maryland and in every state in the nation, in poorer neighborhoods, it's difficult to get providers to provide the access of care that we need. And the block grant type proposal you're making could very well lead to lower reimbursement rates for Medicaid patients, fewer services being provided, and less eligibility, which means there'll be additional pressure for providers not locating in underserved communities. I just urge you, as you look at this, to develop the accountability system to make sure that we are providing top care to all communities in this country, because today we're not meeting that goal, and I'm afraid that if you turn Medicaid into a block grant program, you're going to find a much more difficult circumstance for underserved communities to have adequate health care.
Mr. Chairman, can you tell us what the plan is for the vote series in terms of questions, and are we going to keep rolling?
We're going to keep rolling.
Okay. If
Just
I don't
like
get
the
that,
Army.
submit questions for the record, but.
All the Marines do it better. Senator Hassan.
Thank you, Senator Roberts, and I want to thank the Chairman and Ranking Member Wyden for having this hearing, and thank you, Secretary Azar, for being here today. As others have noted on this this committee has passed bipartisan legislation addressing the high cost of prescription drugs, and Senator Cassidy and I have been working with our colleagues on the Help Committee to end the practice of surprise medical bills. The administration's focus should be on working with us to get those bills across the finish line and bring relief to patients and families, not on cutting Medicare and Medicaid. Secretary Azar, according to the Kaiser Family Foundation, nearly 4 in 10 adults with opioid use disorder receive their care through Medicaid. State Medicaid programs cover the cost of naloxone, medication-assisted treatment, residential rehabilitation, and outpatient therapy. Simply put, Medicaid saves lives. Moreover, according to your department, quote, the evidence is strong that treatment in managing substance use disorders provides substantial cost savings, close quote. Secretary Azar, this is a woman named Ashley Raymond who lives in Enfield, New Hampshire. This is a picture of her with her husband and her 2 children. She started using opioids at age 14 and was unable to access treatment until getting coverage through Medicaid. I met Ashley last year when I visited Dartmouth-Hitchcock Medical Center's Moms in Recovery program for pregnant or parenting moms grappling with substance use disorder, where Ashley is a client. Without Medicaid, she would be unable to afford her treatment or her prescription medication. Mr. Secretary, your own department recognizes the savings, both in lives and in federal spending, achieved through a strong, sustained investment in Medicaid funding for treatment and recovery. How does that square with a budget that would cut almost $1 trillion from Medicaid?
So thank you. I hope that we will have your support for a new state option in the budget that would actually extend Medicaid coverage for pregnant women who are suffering from substance use disorder
but what I am curious,
60 days to 1 year postpartum.
But how does a almost $1 trillion cut square with our understanding that Medicaid saves dollars and saves lives? Because according to the CBO, your proposed cuts would cause states to start the process of ending their Medicaid expansion programs, which would put 17 million Americans at risk of losing coverage, including 57,000 people in New Hampshire. Your budget doesn't slow the Medicaid growth rate by addressing the rising cost of health care. It does so by cutting funding and eliminating access to coverage.
So I may be incorrect, but I think the CBO analysis relates to previous budget proposals as opposed to this one, which is a broader allowance in the budget for us to work together with Congress to address how we can fix some of the perverse incentives in Medicaid that, for instance, have an incentive towards able-bodied adults in the system over pregnant women, age, blind, disabled, and children of traditional Medicaid.
Let me say this. I will follow up with you, but those proposals, too, essentially are cutting eligibility and keeping people away from health care as opposed to looking at the rate of growth in health care costs. So let's move on to a second question. As others have mentioned, your administration continues to support efforts to repeal the Affordable Care Act, including backing the lawsuit that would strike down the law in its entirety. The president claims that he wants to protect patients with pre-existing conditions. Yet, if the Affordable Care Act is repealed, health plans will once again be able to deny coverage to individuals struggling with substance use disorder. Now, in response to Senator Carper and Senator Menendez, you said that those protections were somehow meaningless. I will tell you, to the people in my state who have pre-existing conditions who can now get health care and don't face bankruptcy if they get sick, this is not meaningless and this is not abstract. Can you point to specific policies in your budget that would explicitly protect not just patients struggling with substance use disorder, which would become a pre-existing condition, but also pregnant women or people with diabetes or heart disease from receiving a coverage denial based on what their plan could once again deem a pre-existing condition? Are there specific elements in your budget that provide those protections?
There would be no change to the Affordable Care Act that doesn't protect pre-existing conditions. So even if at some remote date and the remote possibility of the Supreme Court final decision around the Affordable Care Act, the president, it will not allow there to be any statute come out that he will veto it if it does not have adequate protections for pre-existing conditions. That's
and you know,
in our
we
budget.
would be a lot further along in the process of strengthening this bill, strengthening our healthcare system if you all weren't in court trying to tear it up. To echo what Senator Menendez said, you've had 3 years to come up with proposals. I am out of time. I will follow up with you in your office about some of the recent settlements that we've seen and things we can do to prevent perverse incentives in terms of electronic health records and misuse of them. Thank you.
Mr. Secretary, there's been a coup here, and Senator Brown is not here, Senator Bennett is not here. Senator Cornyn, please.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for doing an outstanding job, and please convey our appreciation to the good folks at HHS who do the work day in and day out, which we very much appreciate it. So I guess I'm going to take the bait. Many of our colleagues have talked about the lawsuit against involving the constitutionality of the individual mandate in the Affordable Care Act, and as you correctly point out, it could be years before that litigation is finally concluded by the Supreme Court. In the meantime, the leading candidate for the Democratic nomination for President of the United States is proposing to do away with all private health insurance, including the Affordable Care Act, and replace it with Medicare for all. So if you're a member of a labor union and you've negotiated a good health care coverage, you would be prohibited from keeping that coverage, and would everybody be forced into Medicare without having even paid the premiums over your lifetime to be able to help contribute to the cost of it. What would be the consequence to our public health system in America if Medicare for all became the law of the land?
Medicare for all would be devastating to America's seniors and the American people. You know, right now, America's seniors get a real benefit through Medicare, and that's what we call cross-subsidization. Basically, Medicare underpays doctors and hospitals, and as a result, commercial insurance has to overpay providers just to keep them in business. If we move to Medicare for all, or even things like Medicare options that rely on Medicare rates, that gig will be up for America's seniors. That benefit will be gone, and what will cause is, like we see in other socialist and European systems, a two-tier system of health care. The better hospitals, the better doctors will flee from that system and go off the books, and so we'll reduce access for America's seniors. And as you said, it would take away what people like. 180 million Americans have private insurance through their employer or through their labor union. That would be stolen away from them. People want improvement in health care, but they like their settled expectations there. That's why the president's philosophy is protect what works and make it better. Don't take away what works for people.
Secretary Azar, talking about prescription drug reform and bringing down the cost to consumers and to the government, I supported the Finance Committee bill, the bipartisan Finance Committee bill, and look forward to continuing to work on that as well as other proposals. But we actually have a couple of bills that have made their way out of the Judiciary Committee with regard to patent gamesmanship. One that addresses the patent thicket problem where drug companies, for example, who make the drug Humira, have over 120 separate patents which block competitors and lower prices for consumers from American consumers. Meanwhile, in Europe, there are 5 different competitors available for consumers in Europe. We have this bill that I've introduced with Senator Blumenthal that was voted unanimously out of the Senate Judiciary Committee. We've tried to bring it up on the floor several times, but the Democratic leader has objected to it and blocked it on multiple occasions, even though he admits it's a good bill. He says it doesn't do as much as he wants to do, and I'm willing to do more, but let's bank what we have in hand right now. If the Senate were to pass it and it were to come to the President's desk, would you recommend to the President that he sign that into law?
So I don't know if we have a formal statement of administration position on that piece of legislation. I'll have to check and I'll get back to you on that. But your leadership on ending these patent thickets is vital. We need to address them. So the particulars on that statute I want to get back to you on. But you're absolutely correct. Just one drug alone, the savings from biosimilar market entry would be billions of dollars of savings, but they layer patent upon patent upon patent, late filed patents, manufacturing process patents, just added, extending beyond anything that one would have thought of as the original deal for intellectual property when the original products are approved. And it's what's stopping us from having a robust biosimilar market here in the United States. We're approving historic levels of biosimilars, but they have to get to market. They've got to be reimbursed. There's got to be financial incentive to use them.
Mr. Secretary, the Medicaid fiscal accountability rule is a concern to my governor, and in the state, we're worried, their stakeholders are worried about the rule as proposed could lead to hospital closures, problems with access to care, and threaten the safety net. I would just ask for your commitment here to continue to work with us and stakeholders in my state and around the country to make sure these concerns are addressed. Would you make that commitment?
Absolutely. We with the MFAR rule, we will work with states to help them recreate their practices in ways that are in conformity with the statute and try to be fair and equitable in all of our dealings with states.
Senator Casey.
Thank you, Mr. Chairman. Mr. Secretary, good to be with you again. Thank you for being here. I'm holding a picture, as a lot of our colleagues have, of folks that we represent. These are the children of Erin Gabriel. She's from Beaver County. You were born in Cambria County, about 5 counties away to the west. The 3 children, and you may be able to see it from a distance, but I think you can see at least the outlines of the picture. The 3 children in here are Abby, who's in the wheelchair, Bridget, and Colin. Each one of these children, all 3 of them, have autism. They all receive the benefit of Medicaid. Thank God for that. Erin's children, depicted in the picture, represent, I think, why we have a Medicaid program. Here's what Erin Gabriel said to me, quote, "My children's health and lives are so much better because of the Medicaid services they receive, and they need to see their doctors and specialists much less because they receive these services early." So their lives are much better, but because they got services early through Medicaid, they need to see their doctors and specialists much less. When we debate either the new regulation that Senator Cornyn just referred to, which is a subject of a lot of debate and real concern, or whether we debate the budget cuts to Medicaid, and I know so many colleagues on both sides of the aisle will be thinking about families like Erin's. I'm also thinking about a part of my state that you're familiar with, and I think a lot of people are. I represent a state that has 67 counties, but 48 of them are rural. And I show you a map of the state, but you look at most of the state, and it's a state of rural counties. We have, I think, last count, the largest rural population in the nation of any state. We've got about 3.5 million people that live in rural Pennsylvania. Some states have a huge rural population, they just don't have as many people. So when I think of rural Pennsylvania and rural America, we're of course thinking about rural hospitals, and you spoke to some of the concerns you have about rural communities. I think about the jobs at those hospitals. In my state, 25 to 30 counties, the first or second largest employer in the county is the hospital, and they're already operating under very tight margins. We know that rural children use Medicaid and CHIP at a higher rate than urban kids. That's actually a fact. 45% of rural and small town kids get their health care through Medicaid and CHIP. Rural children were 29% more likely than urban kids to live in poverty. So if you're a child in a rural community, the Medicaid program takes on even greater significance than it does for other children. We know that in 2018, the uninsured rate for children actually went up for the first time, as Senator Wyden said, in a decade. So those are concerns that we have. And then we read the details of this year's budget. The Medicaid cut is $920 billion. And then you have the regulation that not only Senator Cornyn's governor, but a lot of other governors in a bipartisan way have real concerns. In fact, the NGA letter dated January 29th says, quote, "We're concerned that the proposed rule as drafted would significantly curtail the long-standing flexibility states have to fund and pay for services in their Medicaid programs," unquote. So I ask you, on behalf of Erin Gabriel and lots of other families and the worries that they have that the Medicaid cut will hurt their family, and the changes to Medicaid expansion, the 17 million who are covered by Medicaid expansion, many of them with an opioid or addiction problem. How do you, number one question is, how do you justify those cuts? And number two, can you guarantee Erin Gabriel's children, or guarantee Erin, that her children will never lose their coverage under Medicaid as long as you're the Secretary of Health and Human Services?
Well, obviously, any changes to Medicaid are going to have to be done on a bipartisan basis, given the makeup of both houses of Congress. And so these are proposals that we think actually fix some of the poor incentives for children in our system. You know, the Medicaid expansion created a very perverse financial incentives for states to focus on able-bodied adults over the traditional children, aged, blind, disabled, and pregnant women in those programs. And so part of our budget is a focus on actually how do you restore the focus there and make sure Medicaid is there for them.
But just answer the question about the children. Will they lose coverage? Those
Well,
three
nothing-
children that have autism, will they lose
Nothing,
coverage?
there's nothing in our budget that proposes to change the mandatory eligibility categories of traditional Medicaid.
I just hope you could at least guarantee that 3 kids with autism will never lose coverage as long as you have power. Thank you, Mr. Chairman.
Senator Roberts.
Thank you very much, Mr. Chairman. Thanks for coming back. Mr. Secretary, thanks for coming. I think you're doing a good job. It's an even-numbered year, so you get adjectives and adverbs that are a little tough from the other side of the aisle, maybe here too, but I think you're doing a good job. I have 105 counties, by the way, and there's about 6 that are not rural. And 82 critical access hospitals that we have in Kansas, and we are facing difficult situations way out there. And you are proposing a new model to allow these hospitals to convert to what we call an emergency facility that does not maintain inpatient beds. And we've seen this type of proposal recommended by MedPAC and other groups in the past, but it's new to the budget this year. And the budget proposes these newly converted hospitals be reimbursed at Medicare outpatient rates plus an additional payment to assist with capital costs. Now, last year, along with the rest of the Kansas delegation, we sent a letter to you, well, not to you, but to CMS, requesting that the agency work with Kansas hospitals in developing a pilot program for this type of model. They were just in to see me yesterday, and I told them I was going to see you. So I'm going to ask you on their behalf and my behalf an update on when we can expect to see a new model from the agency.
So I'm afraid I do not know the details on that Kansas model. I'd be happy to ask the CMS administrator.
Well, there's
to get
several
right back to
models,
you.
and you're working on yours. I'm just,
Yep.
can you give me a time frame of those 86? Yeah. I would imagine there's 10 to 12 on the edge. If we could just get some certainty and predictability, that's, really what I'm asking for.
So the big change, the one that I'm very supportive of, and I know you've been supportive of, the one you mentioned around critical access hospitals, boosting payments and allowing them to focus as emergency hospitals and not have to support the inpatient beds if they're not financially viable to them. That would require legislation, not models. So that would actually require
I have a bill on it,
there.
and I think a bunch of people are on it just as well. Let me move real quickly. The 96-hour rule. If there's anything that I think our rural care delivery system folks out there do not care for, it's that. And that requires our critical access hospitals as well to have a physician certify in writing for each admission that the patient is expected to be discharged or transferred within 96 hours. On top of the requirement to keep patients' average length of stay to 96 hours or less, this is a very burdensome and redundant regulation. It can force hospitals to transfer or turn away patients. That's being done. They could have provided with high quality care. I know of several situations that have happened when a person came in with a diagnosis that was not correct, not the fault of the folks there, just the way that it happened. Obviously, couldn't come back in until 3 days, even though the situation was very dramatic. Can you explain the decision process to include this policy in the last 2 budgets, considering the proposal was not included in budget requests prior to last year? Last year's budget indicated that repealing the physician certification requirement would have 0 budget impact. This year, the request states that the budget impact for this policy is just not available. So if you could, what happened in the last year that accounts for this change?
I don't know the difference in modeling there, but thanks to your leadership, our budget does propose to get rid of that 96-hour rule. It has all the absurdities that you have talked about. And so we're going to keep pushing. We want to make sure that providers can spend more time with their patients instead of complying with unduly burdensome regulations. And one of them includes removing this 96-hour physician certification requirement. That's an excess burden. I think even as you describe it there, it causes people to tilt their head and say, that's really, you have to be able to predict before somebody can come in exactly how it's going to work. So we want to keep working with you to get rid of that.
I really appreciate. Thank you again for doing good work. And, Mr. Chairman, I yield back 30 seconds.
Before Senator Whitehouse asks his question, for the staff of people that aren't here, I need to know if there's people coming back, because we got to let him go by 12:30 anyway. But between now and 12:30, there's no sense of keeping him here if people don't have a question. Senator Whitehouse.
Thank you very much, Mr. Secretary. I want to raise with you a Rhode Island situation that continues to bedevil me. For a while, Rhode Island has been in kind of a reimbursement hole with lower reimbursement rates than nearby Connecticut and Massachusetts. We were not a high-cost reimbursement area. We were already undercompensated. Then came October of 2018. In October of 2018, your CMS administrator, Ms. Verma, unilaterally undid a rule, something called the imputed rural floor, which made our payment discrepancy to neighboring Connecticut and Massachusetts worse by 20 to 25 basis points. She created this situation where here in Rhode Island, we have Westerly Hospital at a 1.05 roughly reimbursement rate, and half an hour down the road, at Lawrence and Memorial Hospital in Connecticut, 1.3525. Do the math. What's the difference between 1.05 and 1.35? It's a 30% discrepancy. And if you go over here to St. Anne's Hospital in Massachusetts, which is literally 5 minutes from the Rhode Island border, they're at 1.28 compared to 1.03. Do the math. That's a 25% discrepancy. And what we got told at the time is, don't worry, there's going to be this big reform that's going to smooth it all out. I feel I was lied to. I don't think there's been any sign of this reform. And then comes this budget. In this budget, not only is there no reform, there's a demonstration project, which is the kind of thing that gets put together in 5 minutes overnight when you don't have a real plan. And guess what? The demonstration project has the nerve to say that it's going to be the purpose. Here's the language from your budget. The demonstration aims to reduce sharp differences in the wage index and Medicare payments between nearby hospitals. Does that not mean that your organization knows, that Ms. Verma knows, that sharp differences in the wage index and Medicare payments between nearby hospitals are a bad thing?
So, Senator, I share your anger and frustration about these disparities that are impossible to explain. Simply by geography. In fact, I keep with me this chart because I do share that concern with you. The wage index is a perverse.
To be specific to my question, you do agree that sharp differences in the wage index and Medicare payments between nearby hospitals, your language, are a bad thing, and that is why you want to reduce them.
I do agree.
Great.
I would like to work with,
So,
if I can work with Congress.
Could you please get Ms. Verma to undo what she did over a year ago? She unilaterally made these sharp differences in the wage index and Medicare payments between nearby hospitals worse by a factor of 20 to 25%. And we were already under-reimbursed. Lifespan Hospital reports a $25 million loss in the last fiscal year because of the decision that she made. You can go to other hospitals with similar patient mixes around the country, and they would be making money because of the way in which they're reimbursed. We had our reimbursement hole unilaterally dug deeper by 20 to 30% by your CMS administrator We were not told the truth about what was going on at CMS. We now have this bogus demonstration project coming out of no place, as best we can tell, that admits that it's wrong to be doing just what she did. This is a real consequence for our hospitals. They are in real pain as a result of this. And it is tiresome to no end that your bureaucracy just sits around doing nothing about this, making it worse, actually making a problem that you identify as a purpose to solve deliberately and unilaterally worse.
And Senator, thank you. I do want to say neither of us, the administrator or myself, have the unilateral control over regulations on these policies, but...
You did this one. She did. She did it.
Even within the administration, none of us have the unilateral control. And the challenge with the wage index, and it's you and I, and we've had such a good partnership, you and I enjoy working with you.
I don't blame you, I blame her. I want you to fix it.
Senator Cassidy.
Hi, Mr. Secretary, how are you?
How are you?
The antibiotic market. Your wheelhouse as a person very familiar with the challenges in the pharmaceutical industry. We have these very resistant organisms, and you want to have an antibiotic that covers them, but you're going to use it on very few people. And most of the people you use it upon are either on Medicare or Medicaid. If you throw in VA, it's going to be probably at least 2/3, maybe 4/5 public payers. One idea has been to carve out these extraordinarily important but rarely used antibiotics from the DRG and to put them into Medicare Part B, but making sure you have the accountability associated with the stewardship program. Knowing that we may end up saving money if you have a shorter hospital stay, and of course lives if you have a more effective antibiotic. Any thoughts about that? And maybe you can't be official, but just because of your expertise?
No, you actually put your finger on exactly the problem with antimicrobial resistance and the next generation antibiotics that we're developing, and it's something that I'm actually wrestling with our team right now. We have essentially a market failure, as you describe it so rightly. We want drug companies to invent an antibiotic that won't get used.
Yes.
That is an economic problem. So I am looking at different approaches. One of them could be...
More properly will be used rarely and appropriately.
Exactly, as opposed to broadly. One approach could be around our payment policies, as you mentioned, direct pass-through payments. I will look at that. The other is, it is increasingly resembling our bioterrorism countermeasures programs, where the government basically is the only purchaser for value of certain products. It's almost a stockpiling government purchase issue. I've actually commissioned work to look at this. We have tools to deal with market failures, and we need to look at how those tools could be used here for AMR.
And I will say that there's at least one antibiotic that the United States taxpayer invested hundreds of millions of dollars into development and was sold for like $16 million to a company from India because the business model didn't work. As you say, very expensive to develop but rarely used.
Right. We have got to ensure that there's either a commercial marketplace that's viable to sustain these or a government market that will make them sustainable.
Now, you just said something which, of course, my ear perks up, that you're actually working perhaps on a solution regarding this. Now, would this solution be in the offing? What stage is this work?
So it is still foundational, so I'd love to hear your ideas, and we could work together offline about that. I've got my teams working on this. I've identified with some of the recent, you can see in the Wall Street Journal, some of the recent challenges of manufacturers of these novel products and them even not surviving necessarily. And it's an economic problem.
And we'll make an appointment to bring in some ideas to you if you don't mind.
Thank you, thank you.
Next, another issue I'm interested in, the mentally ill. Currently, they lose their Medicaid when they go into a jail setting. And so even before they're adjudicated, they lose their Medicaid. Now, if they're on a mood stabilizer, for example, that works for them, but it's not on the jail formulary, they may get either not placed on something or placed on something inadequate, and then they decompensate and their behavior worsens, or when they're released, they are now kind of wandering on the streets as opposed to holding a job and paying taxes. I think the budget, the administration's budget allows them to continue coverage for 6 months while in jail. But I would ask, since the definition of a jail is that you stay there until you're adjudicated, basically, and that can be up to a year, why not extend it for an entire year? And if not for the entirety of the Medicaid coverage of care, at least for the mental health issue, I think that would go a long way to addressing the revolving door of the mentally ill going in and out of jail with disruption of care. Any thoughts on that?
So it's an important question. We were able to get in the budget this year this prohibition of states terminating Medicaid coverage for the first 6 months of incarceration and requiring that process to facilitate the enrollment on release so that we can avoid relapse and other health crises. So we got that far, but you raised an important issue about whether one should go further. I'm happy to work with you on that, share the issue around serious mental illness and incarceration and that transition, that handoff both into incarceration as well as the handoff from incarceration out to community integration.
Yeah, there's at least some suggestive data out of Los Angeles that the mentally ill are cycling through jails. And so the degree that we stabilize that, I think, is the degree to which we begin to fundamentally address the issue of homelessness. I yield back and thank you.
Senator Warner, you better be ready to go.
Mr. Chairman, always.
Go ahead.
Mr. Secretary, great to see you. I want to start on a question that's already been asked, but want to give a slightly different frame on that, and that's the Medicaid fiscal accountability regulation. And let me acknowledge on the front end, I get the goals of transparency, and I get the goals also that there's perhaps not everybody comes with fully clean hands, and this has been a challenge that's been going on for some time. In Virginia, where we finally expanded Medicaid a year ago, we've got about 375,000 people who've gained access to health care, critically important. I absolutely agree with the bipartisan letter that the national governors and the former governor, myself, I really want to make sure, you said you'll work with the states, but we really, state, as you probably are aware, all states are going through their budgeting process right now. And the way I read this regulation is it could potentially come out sometime later this year and dramatically affect Medicaid eligibility and the payments plans that are in place. And that will wreak havoc in budgets, red states and blue states all across the country. So I hope that you will also commit to working to make sure that we work with the states, but we do so to make sure that we limit the impact, because this regulation will not be, I don't think, finished by the time most states have actually put forward their budget, which they're actually a little bit better than we are in terms of meeting their deadlines. They will mostly be done by mid to late spring.
Yes, so we understand that the changes that would be implicated here want to be fair and equitable, and we understand also the budget cycles of states and commit to working with the states to be reasonable in our approaches. Not every state has these improper intergovernmental transfers. Some of this is transparency to even identify what's going on to make sure real money is being spent in the program. And we'll work with states also to help them design ones that are compliant in the future. We're going to try to be very reasonable. These are our partners in this program. We're in this together. We're not trying to cut Medicaid through the MFAR regulation. It's just trying to make sure it's the right kind of spending.
There are, having visited with some of the governors, there is grave concerns, candidly, that is part of the goal of the administration, and I hear this from both Democratic and Republican governors, and I think it's reflected a little bit in the president's budget. So I hope you will, I'm going to be following this very, very closely. And if there is a new systemic approach to this that allows everybody to bring a little cleaner hands, I get it. Let me move, I got 2 minutes left. Your interoperability rule. I think we talked about this at one point. I think one of the grave mistakes when, again, there was large bipartisan agreement, the one piece around Obamacare was, we need to move to EHR, we need to make sure we have better use of data. And one of, I think, the major mistakes that we didn't make was we spent all that money without any interoperability. My background was in cell phones. If we would have never had a wireless industry in America if we hadn't required interoperability between systems. So I support the efforts, but we've also seen in the years since that's been put in place, the privacy, cybersecurity concerns, the vulnerabilities of this approach is we've really got to be thoughtful about it. And I, frankly, do not believe, I've took great exception to your CMS administrator who said that, technology companies are doing a good job of protecting this information. I don't think they are. It's not just the Equifaxes of the world that are grossly screwing up, and I think we've seen lots and lots of history amongst the healthcare providers. So I want to make sure you move forward with this ruling, but I also want to make sure that consumers have rights, for example, to delete their information, to have privacy protections. How do we make sure, in this last 30 seconds, it's a much longer question, I've got a number of other questions for the record on this topic, that we get this right and that we don't. I agree with you getting to the goal of interoperability, but I'm really concerned that we're not taking the cyber and privacy protections fully into consideration.
So first, thank you for creating the Cyber Security Caucus. If you'd ever like to come see our cyber work, very happy to host you with that.
One thing I should say, we've also contacted almost all the healthcare systems, and you would be amazed at how they will acknowledge and will share with the department how unprepared they are.
Yes,
Please, sir.
For hospital and other healthcare CEOs, I think cybersecurity is probably the #1 risk management issue for them. In the interoperability rules, absolutely hear you, and we want to make sure the patient's at the center of consenting to disclosure, interoperability, use, transfer of their information. So that is actually core to everything we're doing is patient ownership of their information and that transfer and consenting to that. So as we work on final rules on interoperability and information blocking, that kind of protection, patient ownership is centerpiece of what we're trying to work towards.
I know my time is up. I just want to simply say we want to work with you on that because I think there are some very mixed signals coming from the administration. Thank you, Mr. Chairman.
Senator Brown.
Thank you, Mr. Chairman. Mr. Secretary, welcome. Good to see you. Colorectal cancer is the second leading cause of cancer death among men and women combined in the U.S. On top of that, the American Cancer Society estimates there will be more than 100,000 new cases of colon cancer diagnosed just this year. The good news is we can prevent it or treat it successfully if we catch it early enough. Thanks to the ACA, colorectal cancer screenings are considered a preventive service, and as a result, they're available at no cost. No copay, no deductible, another thing that's important in the Affordable Care Act in spite of your boss's efforts to repeal it. Unfortunately, due to a glitch in the law, if you're a Medicare beneficiary, you get that cancer screening. I know you know this issue well. A polyp's removed to prevent the potential for cancer. You wake up with a hefty copay. It doesn't make sense. It discourages folks from getting the life-saving screenings. I say all this because I'm thankful the President's budget includes my legislative proposal to eliminate the unexpected out-of-pocket costs some beneficiaries experience when they get the screening. My bill, the Removing Barriers to Colorectal Cancer Screening Act, ensures that preventive colorectal cancer screenings are fully covered by waiving the Medicare cost-sharing requirements for preventive colonoscopies, even if a polyp or tissue is removed. My legislation has 61 co-sponsors, obviously a lot on each side, 339 supporters on the House side. I would like to ask publicly, Mr. Secretary, for your commitment to working with me and with the Chairman and Ranking Member Wyden on getting this done.
Well, absolutely, and I wanted to thank you, Senator. You were the one who brought this real anomaly in the statute to my attention. It's really absurd that a senior goes in for a colonoscopy expecting to have no copay, and if they happen to find a polyp, which is exactly what we're screening for, they come out of anesthesia and they get a bill because then it's converted from a screening into a procedure. So you raised this to my attention, and I've worked to champion that, and I'm just so delighted it's in the budget, and we're going to work with you to get this passed.
Good, and I thank Chairman Grassley and Senator Wyden for their interest, too. Two other issues real quick. Last year's budget hearing, I asked you to commit to a number of things related to FDA efforts to curb e-cigarette use. When I asked if you would, quote, commit to reducing nicotine in cigarettes to non-addictive levels, you answer, and I quote, absolutely, that's the nicotine rule we'll be working on. You went on to say you'd be driving forward the effort to restrict flavors in e-cigarettes with full vigor. Your words, that you wouldn't hesitate to take, again, your words, more aggressive action if necessary to curb youth use. Despite these strong commitments, HHS dropped its nicotine reduction proposal from the unified agenda. HHS also backtracked on its promise to remove all non-tobacco flavored e-cigarettes from the market. The final guidance instead, released last month, exempted disposable flavored vaping products and flavored e-liquids. Thousands of flavored e-liquids, e-cigarettes remain on the shelves. The huge progress we made for 50 years bipartisanly is in jeopardy because of that. Just, if you please tell me, why has the department decided to cave to the industry and political pressures and step back from those efforts?
So actually, on the e-cigarettes and flavored e-cigarettes, where we ended up was at an even more aggressive posture than when we spoke last year about this issue, actually requiring that those child-friendly and child-used flavors come off the market pending PMTA authorization. So we actually advanced to a more aggressive posture than even when we spoke before, because at the time Commissioner Gottlieb had only been speaking about site of sale restrictions there. So I want to be very aggressive on this one. February 6th, the enforcement date has hit us. In terms of disposable flavored, the disposable cigarettes, if we see utilization there and disposable, a shift into that, we had seen really the pod-based, the replaceable charred pod-based items were driving this. If we see movement there, we'll certainly take enforcement action. Nothing has to be set in stone in terms of our enforcement policies here. We want to keep these away from kids, even as we try to make the other products available for adults to move off combustible.
Well, I appreciate your answer, and I do believe you're sincere and genuine. I also believe there's a White House where the White House on Thursdays and Fridays looks like a retreat for tobacco executives, but I still am concerned about the flavored disposable products that are out there on the shelves, and you need to do better, we need to do better. Last point, Mr. Chairman, quickly. President's budget recommends a cut of more than 9% HHS. You can claim the budget prioritized spending on direct services, but the primary payer of direct services is Medicaid. The budget cuts more than $900 billion from this essential program, contrary to a presidential promise in his campaign. Whether it's the flu, addiction, coronavirus, or another public health threat that we don't even know about yet, Medicaid's the most important tool states have to prepare for the inevitable and ensure people get care. You may also try to argue the budget does not propose cuts to Medicaid, but would instead slow the growth rate. That doesn't mean much to the hundreds of thousands of Ohioans who get left out. Cutting Medicaid by hundreds of billions of dollars will cause hundreds of thousands, maybe millions of people to lose health care. I remember chapter and verse working with Governor Kasich, a Republican in my state, to expand Medicaid. That meant so much for our state. The president claims to care about protecting pre-existing condition. His support of the ACA repeal lawsuit, combined with his health care vision in this budget proposal to slash Medicaid, all to pay for huge tax cuts for the wealthy, just doesn't work for public health in our country.
Well, again, I just want to, as we close, just wanted to thank you for your support and work on the colorectal cancer issue. I just think that's going to be a huge advance for patients if we can get this passed out of Congress.
Okay. I guess that means you don't want to say much about them.
We can talk about Medicaid. You know, on the Medicaid program, as you said, we are reducing the rate of growth from 5.3% to 3.1%.
Doesn't sound like
in every single year of the budget outlook, Medicaid will increase its expenditures. And what we're trying to do, we set an allowance there to work with Congress together on how we can grant flexibility to states related to expansion populations of able-bodied adults, how we can control the rates of growth there, and how we can also fix the perverse incentive where we favor able-bodied adult coverage over kids and pregnant women and age-blind disabled, the traditional Medicaid beneficiaries that we now actually prejudice against in the system. So that's sort of at the heart
would
of
you,
what
in
we're trying to do.
last statement, Mr. Chairman, would you, the next time you're at a cabinet meeting or the next time you see the president, I don't know if he knows he's lying about this or if he's just used to doing it, but would you correct him when he says he's supporting the consumer protections for pre-existing condition? Because he's trying to take them away with the Texas lawsuit. He tried to take them away legislatively here. And I assume it won't change him. He'll still go on the campaign trail and talk about how he supports pre-existing condition. But if somebody of your stature tells him he's lying, maybe that would be helpful.
Senator Hassan, you have one question, I was told.
Yes, sir. Thank you.
And then we got to have members speak, other staff speak up here because we're going to adjourn this meeting. I've got to go vote too.
Yeah.
Go ahead.
And so do I. And Secretary Azar, thank you for, again, for being here. One note, we are already hearing from pediatricians in New Hampshire that 1 week after the ban on pods, flavored pods, teenagers are already migrating to the disposables. They've discovered they're cheaper in the bargain. So it's taken 1 week for teenage behavior begin to change, and they're still using these devices, and the harm is still happening. So I'd love to follow up with you on that. But the question I had was about transparency and recent anti-kickback settlements, because I think it's something we could work on together. The Department of Justice recently announced a settlement with an electronic health records vendor that was paid by Purdue Pharma to display inaccurate data to providers so that they would unknowingly overprescribe OxyContin. Patients and providers have to be able to rely on electronic health records as a source of accurate clinical information. What steps are you taking to keep this kind of misbehavior, to put it lightly, illegal behavior, from happening again?
So I just want to make sure I'm understanding this, because I'm not familiar with that particular aspect of litigation. Is this an issue where a drug company got basically in the electronic medical record essentially an edit in there that coached towards a certain product?
No, it prompted physicians to prescribe an opioid again to a patient when the patient might not otherwise have needed it. So they were overprescribing, and the prompt was essentially paid for by Purdue to the electronic records.
I'd like to get back to you, if I could, on this one to make sure that I'm correct, but I believe we've actually had efforts working with the major EMR vendors, Epic, et cetera, Cerner, to try to get them to actually put the non-opioids at the top of the list as they, in terms of pain medication, so it's not right there.
Right.
But happy to.
This is really about the integrity of electronic health records. We have to be able to depend on them. Doctors do too. There was a second settlement which goes to some of this same issue about making sure that we're policing the drug companies correctly. Second settlement announced in January, a nonprofit copay assistance program was found to have taken money from the drug company Insys for the sole purpose of paying Medicare copays for their fentanyl-based pain medication. Of particular concern, this nonprofit knowingly facilitated access to this highly dangerous drug for off-label use. We've seen an increasing number of these settlements in recent years as drug companies become more sophisticated in their efforts to drive overutilization. One way to protect beneficiaries and save taxpayer dollars is to leverage transparency in order to identify these illegal relationships before they can take hold in the Medicare program. So does your department collect data on payments from drug companies to nonprofit copay assistance programs or payments to electronic health record vendors that could help identify this costly and dangerous behavior in real time?
Can you give a short answer to that?
I appreciate that, Mr. Chair.
I do not know about, for sure, what level of disclosure is. Let me check and get back to you on whether they submit that to Medicare and Medicaid on the price reporting. It may be in that context.
All right, well, I'd love to work more with you on it. Thank you, and thank you for your indulgence, Mr. Chair.
Secretary Azar, thank you for being here today. Like many of my colleagues, I hear from seniors across my home state of Montana who are struggling with high out-of-pocket costs when it comes to their prescription drugs. And that's why I'm working across the aisle with this committee to lower the cost of prescription drugs and establish an out-of-pocket maximum in Medicare Part D in order to provide Montana seniors with some badly needed relief. I'm glad the administration voiced its support for such a proposal in the President's budget. My question, Mr. Secretary, is can you explain how an out-of-pocket cap would affect the average senior in Montana?
Thank you, Senator, and thank you for being willing to be part of this bipartisan effort on drug prices. Let me give you a made-up example, but because I don't have Betty's actual name, but let's say there's a Betty in Helena who uses a drug called Revlimid. This is used to treat multiple myeloma. Under the current Medicare Part D benefit, she would have to pay $6,350 before she would hit what's called the catastrophic cap in Medicare Part D. Once she hits that cap, after over $6,000, she's going to pay 5% on all drug costs after that point, to infinity. That can add up to a lot when you're talking about these kind of expensive therapies. Now, those costs also would be front-loaded in the benefit year, so she's going to pay more when she's in deductible and the donut hole period. She would likely move quickly through that deductible period and get to the catastrophic, but 5%. Now, in the plan, the Grassley-Wyden legislation out of this committee that you have supported, that's going to provide two important benefits to her. First, Because of the savings we get from the inflation penalty cap, we create a new catastrophic cap at $3,100. And at that point, it's a complete cap. She will never pay again for drug expense during that year. In addition, a critical innovation that's been made is to allow her the option of spreading that catastrophic cap over a 12-month period. She could elect to never pay more than $258 a month for her drugs, no matter what her drug expense is. It's an incredible out-of-pocket change for the American senior if we can do this.
Thank you. It's a great example, and it's an important policy that I'm going to continue advocating for, certainly this committee, and getting a vote here on the floor of the U.S. Senate. I want to shift gears and talk about meth for a moment. Many states have been hit hard by the opioid epidemic, but in Montana, we're facing a meth crisis. That's why it's been one of my top priorities in Congress to ensure that our communities, our families, Indian reservations, law enforcement have the resources they need to help combat meth use. In fact, I had the Vice President and Karen Pence came out to Montana in June and got to see it firsthand what's going on when we visited Billings. The efforts include states like Montana because we need to make sure we target these available resources where they're needed to prevent drug overdoses. In fact, I'm pleased the President's budget increases funding for state opioid response programs and allows states to use these funds to address the abuse of meth in addition to, of course, the scourge of opioids. My question, Mr. Secretary, is can you speak to the importance of allowing states and tribes to address their unique community needs when it comes to combating substance abuse and drug overdoses?
Absolutely, Senator. As you said, each state's going to be different. Some are facing more of an opioid problem, and some are increasingly facing a meth problem. In 15 of the 36 states that report overdose deaths by drug type, meth use is responsible for more deaths than synthetic opioids even. Between 2018 and 2017, we've seen a 30% rise in deaths from methamphetamine. So as you say, it's a very big issue. These gangs out of Mexico that brought us so much of the opioid crisis, as we have pressured them down on the opioids, they've expanded into commercial grade and commercial scale production and importation of methamphetamine. So I was delighted when Congress in the 2020 appropriation allowed state opioid response grant money to be used by states also for stimulant and methamphetamines. We've continued that policy recommendation in our budget for this year, that flexibility for states to address meth to hopefully keep it from being the fourth wave of the addiction crisis.
And Secretary Azar, in the time I have remaining, I want to thank you also for calling out the Mexican cartels. This is the shift that we're seeing in my home state of Montana. We are a northern border state with a southern border crisis. And that is, once upon a time, the homegrown meth had purities in the 20–30% range. This Mexican cartel meth, as you know, has purities north of 95%. So it's far more potent, price has gone down, distribution has increased. And this is why this is the battle we've got to fight right now back home as it relates to meth. And thank you for your help in that effort. I'm out of time, and I believe Senator Langford, you're up next.
Okay, thank you. Secretary Azar, thank you for being here. Thanks for all the work. You've done a lot of work to be able to help folks have opportunities to get greater health care and greater health care options. I appreciate it very much. I want to bring up something that's new that you proposed that my state actually was first in line to be able to engage in. That's the Healthy Adult Opportunity Initiative to be able to allow greater flexibility on Medicaid so they can tailor it. Oklahoma is not the same as Alaska. It's not the same as Illinois. It's not the same as New York. And so allowing some greater flexibilities. Where does that stand at this point for the Healthy Adult Opportunity Initiative?
So we have put the guidance out to the states and are now really open to working with states. I think it's very important to remember, because a lot has been said about this opportunity for states to apply for this flexibility. This would preserve, the insurance would have to cover essential health benefits. No individual would be deemed ineligible. The eligibility requirements for the Medicaid expansion under the Affordable Care Act would remain. There would not be either partial expansion or partial de-expansion. So this really would be for states to come up with ways in which they can provide a more integrated approach for these able-bodied adults. This is the expansion population, not traditional Medicaid, that's subject to this. And again, only if the state wishes to be doing this.
Right. It's something my state is currently exploring to be able to go through that process. You've also put out some proposals on Part D generic tiering to allow basically a secondary preferred specialty tier for drugs to try to get better benefits out there. If there's any recommendation I can make on that is that we continue to be able to lean in on that and to be able to target generics and biosimilars to be able to make sure it's not just a benefit across the board, but it's really a benefit to those folks that are the consumers, that are the purchasers. Where does that rule stand at this point, and what are your thoughts on that?
So we have proposed that as part of the Part D regulations to create this second, allow the drug plans to have the second tier for specialty drugs. Those are the more expensive drugs. I think the specialty tier right now may be around $660 a month that triggers that. Right now, the regulations actually somewhat disable the insurance companies from negotiating bigger discounts from pharma because it has just the one tier. This proposal would allow there to be a more favorable tier, so not more restrictive for patient access, but a more favorable one to entice drug companies to give even more discounts in order to secure access to that tier of lower cost sharing for the patient.
It's one of the things that several of us in this committee are working through right now to provide multiple tiers and some other options for that and block some of the companies that are preventing drugs from going on the generic tier and pushing it onto the higher price tier. That's something we're trying to be able to work out legislatively. Several of us have mentioned things about the rural hospital relief. My state has seen seven rural hospitals that have closed of late. This is a big issue. Senator Durbin and I are actually working on some legislation dealing with critical access hospitals and getting greater flexibility there. I know you're also in a regulation trying to deal with that as well to allow them to be outpatient emergency hospital access and that critical access. Where does that stand at this point?
So I'm actually very happy that is in the President's budget this year to have Congress authorize us to allow that kind of flexibility so that a critical access hospital could have emergency function, outpatient, but not be subject to all the requirements of inpatient. In addition, the budget proposes that we'd have enhanced payments for those critical access hospitals that would elect for emergency so they could be reimbursed at the regular emergency rate as well as a supplemental amount of payment for them.
Right. Well, we look forward to getting a chance to be able to walk through that because that'll be very important for all of us in rural states. And Senator Durbin and I will continue on with our legislation trying to be able to solve this legislatively long term. The University of Vermont Medical Center made a decision to have a nurse during an elective abortion be forced against her conscience to be able to participate in the abortion. Even though there were other nurses that were available and willing to do it, she was compelled to be able to participate that against her conscience. Your team has reached out to the University of Vermont Medical Center, has made requests of them to be able to find out where they are, what their standards are. It's been months on that. Has there been a response back in that process?
So as you know, with any of these cases in our Office for Civil Rights, we try to actually work towards a resolution that brings into compliance. The University of Vermont Medical Center refused to work with us on that, and reluctantly we had to issue a notice of violation in order to try to get their attention. Where things stand now, because that is a law enforcement matter, I couldn't go into detail about the back and forth on that. But the critical issue is we try to work with providers so that they get commitment to bring themselves into compliance.
Right. Well, we'll continue to be able to watch for that and be able to see what we can do. One last quick question is dealing with nicotine levels in vaping. There's not a standard level of nicotine. Obviously, several of the vaping devices choose to have very, very high levels of nicotine that they know is the most addictive portion of this. This is an area that we've raised to FDA before and to you before to say, is there a way to get a standard for nicotine so that these devices don't intentionally load them up with high levels of nicotine to increase addiction? Where does that stand?
So there's not a regulation under the PMTA, that's the authorization process for e-cigarettes that we have for novel tobacco products, a regulation setting a nicotine level, but in the course now, the May 2020 deadline that the court has set for these e-cigarettes to come in and apply for approval or authorization, under the PMTA, looking at appropriate nicotine levels will be one of the factors that we can examine at FDA in determining if an e-cigarette's entry into the marketplace is, I forget the standard, supportive of the or furtherance of the public health. So that would be one of the criteria that we can look at, is the nicotine level.
Thank you. Senator Cortez Masto.
Thank you. Secretary Azar, thank you for being here. So appreciate it. Like my colleagues, many of us are concerned about the cuts to Medicaid. Similar to what I've heard earlier, in the state of Nevada, we are one of the states that, thanks to the Affordable Care Act, we were able to expand Medicaid. And many, like this young gentleman here, Alex Camberos, who's 28 years old, he's alive today because of Medicaid. My concerns are similar to what you've heard from my colleagues. One, why are we making these cuts to Medicaid? Most importantly, why are we pitting vulnerable groups against one another? And how can you make those decisions when to decide what life to save and what life not to save? Those are the concerns you're hearing from us in this administration. But let me take this even further. I am also concerned about what I have seen happening in Indian country. And let me put this on your radar because I know there's some good work that is being done, but I don't think people appreciate the impact that the ACA has had on Indian country. The law designates IHS as the payer of last resort, helping stretch those dollars further. Medicaid expansion, premium tax credits have boosted coverage and care quality and enabled IHS to collect reimbursements that have allowed them to hire more providers and specialists. It's helped them to ensure that their facility met all required standards, including those required for ongoing accreditation or to undertake any needed maintenance, such as by repairing roofs and heating systems. The reality is that we know right now, in a court of law, this administration is trying to repeal and take away the Affordable Care Act, including coverage for pre-existing conditions. That's the law. That's what's happening. That's reality. It's not conceptual, it's reality. And if that happens, I guess my question to you is, what happens to Indian country? How do we address their needs if we take away the Affordable Care Act, if we take away coverage? What are we going to do to help them move forward and continue to have access to care?
So again, in terms of the litigation position, this has now been sent back to the district court for a searching analysis provision by provision. This is going to take a considerable time, go back to the Fifth Circuit, and then maybe the Supreme Court eventually. So this is actually a rather remote item. At this
Well, actually, let me stop you there because I'm an attorney. I was an attorney general for 8 years. I know what litigation is about. And when you go into litigation, you're setting forth your values and your principles as part of that litigation. So this administration has clearly said they think it's unconstitutional and they want to take away the Affordable Care Act and pre-existing conditions. No matter how long it takes through that course of litigation, you cannot sit here and tell me today that the administration position is that they support the Affordable Care Act and they want to keep that coverage and pre-existing conditions. So don't try to walk around it somehow by saying this is going to be prolonged, so we don't care, it doesn't really matter right now. It does matter. That's what this administration values, and it sets it out, and the American public needs to know that. So please don't start with that. My concern is if it's taken away, right now, let's assume there's a ruling and it's taken away. What are we doing for Indian country?
It's not going to be taken away right now. That can't happen, and unless you decide to work with us on reforming or changing.
So I get that. So tell me, if it's taken, listen, let's speculate. Hypothetical, if it's taken away, what do we do for Indian country? What's the plan B?
So this administration actually has had historic funding for Indian country and Indian Health Service. So we've actually increased the budget by 10% since FY 2018. We've got an additional 3% in 2021. We're making critical investments in the Indian Health Service. We put $85 million in this budget into quality improvement programs. We actually have created the first ever quality office within IHS, trying to bring better outcomes. What I'm trying to drive, and I hope we'll get Admiral Wiaki confirmed as our IHS director, I want to bring a complete quality, safety, cultural transformation within the Indian Health Service. We owe this in Indian country to deliver the finest quality service to our beneficiaries there. And it's not just about getting various facilities to meet their CMS certification, which is, of course, that's a baseline, but it's actually rather quality that's ingrained into the culture of every aspect of what we do in the organization. That's part of what we're doing in our budget, but also what Admiral Wiaki will bring, I hope, if confirmed as the IHS director.
Good, because I agree with you, and I've had conversations with the nominee. I think he's the perfect person for the job, and I think we have to work together to really address the needs of Indian country. So I'm glad to hear you say that, and I look forward to working with you on those issues. Another area I want to talk about is Alzheimer's research. In 2018, the President signed into law the Bold Infrastructure for Alzheimer's Act. It was a bill that I co-sponsored. And it actually takes a public health approach to Alzheimer's by tasking the CDC with overseeing preparedness and surveillance associated with the disease. In December, Congress funded the Bold Act grants. And the CDC is now getting ready to send that money out to states and local centers of excellence. Those funds are going to support Alzheimer's intervention focused on increasing early detection. This budget, my understanding, proposes to discontinue CDC's work on chronic disease management and instead task states with that work using the New America's Health Block Grant. It doesn't appear to include Alzheimer's activity, so I guess my question to you is, does it?
So the America's Health Block Grant on that would actually grant flexibility to states to fund the areas of highest concern. Right now, CDC's chronic disease programs are very siloed, micromanaged by us, this disease, this area, this area, this area. The America's Health Block Grant, if adopted by Congress, of course, would grant flexibility for states to go where they find the greatest need, for instance, perhaps Alzheimer's surveillance, as you're talking about through that program.
Okay, so
I believe that's correct. If I make
if I could just get, because we've been fighting for this funding, and I just want to
answer.
make sure pursuant to the act that the money is still going in and being targeted by the CDC. That would be very, very helpful. I appreciate that. Thank you for being here.
Senator Wyden.
Mr. Secretary, we have a vote on, so you can count on my being really brief. I'm going to try and see if I can cover two things very quickly. As you know, I have been strongly opposed to the department allowing taxpayer-funded faith-based foster care agencies to refuse to work with otherwise qualified parents because they're Jewish or Catholic. 8 months later, your department expanded this taxpayer-funded discrimination, announcing it would allow all of your funded grantees to deny services to people on the basis of sex or religion. So now, not only could vulnerable kids in the foster care system be denied access to qualified and loving parents, an early childhood center could turn away a child from their program because that child's parents are Jewish. Or LGBTQ people could be refused domestic violence services. And you can go on and on. How can you claim that this is protecting the religious liberty of Americans?
So first, we believe all individuals should be treated with dignity and respect in whether it's our healthcare programs or our human services programs. That should be our expectation of every aspect of our programs. But we also enforce discrimination laws that are passed by Congress, and we want to vigorously enforce those. The regulation that you mentioned was promulgated really singling out one particular Supreme Court case, imposing that as an obligation, and also violating, at least risking the violation of the Regulatory Flexibility Act in its implementation. And so we did not feel we could enforce that. We have a proposed regulation out that would require our grantees to comply with all Supreme Court case law, not singling one particular rule out, and also require compliance with the anti-discrimination laws as passed by Congress. But at our core, we believe everybody should be treated with respect in our health and human service programs.
All I can tell you, Mr. Secretary, as I read the law, you went from essentially a pilot project to saying that all HHS-funded grantees could deny services to people on the basis of sex or religion. I think that is a horrendous precedent for this department that is so important to people, and we're not going to get parents that we need for these foster care programs. Let me ask you about one other thing, and that is, as you know, I have felt very strongly that we're in the middle of an enormous transformation in the Medicare program. Back when I was director of the Gray Panthers, it was about acute care. Now it's about chronic disease, cancer and diabetes and heart disease and strokes. And here in this committee, Senator Daines will certainly remember this, we passed on a bipartisan basis the Chronic Care Act, which took a number of constructive steps. It helped the Medicare Advantage programs. It helped technology, telehealth programs. And you could have programs, for example, Medicare Advantage programs, be able to pay for safety bars in a bathroom for those at risk of a fall. My question to you, because time is so short, what can you tell us is being done to make sure that this program gets extended to traditional Medicare? Because as you know, that has been an area where we said, look, there's a lot more to do, but the future of Medicare is not what I was dealing with when I was director of the Gray Panthers, broken ankles. The future of Medicare is cancer, diabetes, heart disease, strokes, and people who have 2 or more of these conditions. So what's being done to address traditional Medicare and expand services there.
Absolutely. So with the Chronic Care Act that you led, it's really important advance in thinking about Medicare for chronic care and also thinking about telehealth as part of that. I'd say actually longer term in traditional Medicare, this is where I'd encourage you to look at what we're doing at the Center for Medicare and Medicaid Innovation around direct contracting for total cost of care. If we can get providers, whether integrated systems or primary care providers, and the applications are due very soon, if we can get them to actually assume total cost of care, we can get out of micromanaging them on the procedures, the individual procedures, instead paying for that longer-term outcome and them having the financial upside of effective long-term management. I believe long-term, that is what causes the investments in real chronic care management, like what you're talking about. They may decide, because they'll have the skin in the game, to put the bar in the bathroom, for instance, or the ramp at the house, or the air conditioner to lead to a better long-term chronic care outcome, because they'll actually have skin in the game working with the patient.
Let's do this. What you're talking about sounds constructive to me. If you could, for the record, give us a brief report about what the department has done since you all took office there, and what are the projects that you plan to do in the next year, I think that would give us a little something to point at. And you've always taken my calls to discuss this, and I look forward to working with you. Thank you, Mr. Chairman.
Senator White, that was a rather uplifting finish to the hearing.
There you are.
So it was good. Thank you, Secretary Azar, for your attendance and participation today. I ask any member who wishes to submit questions for the record to please do so by close of business Thursday, February 27th. With that, the hearing is adjourned.